So today's our focus would be upon the pons, which is a structure that is found in the hindbrain, the rear part of the brain, and we'll be looking at the structure as well as some of the functions that are carried out by the regions that are present inside, and also we'll be looking at the lesions. So this has an attribution to uh, the clinical aspects of the pons as well. So we'll be trying to give a more or less a thorough version where you can understand almost everything that is directed under the region. So first of all, I would like to say that the pons is a structure that is found within the hindbrain, a structure that is found in between the midbrain and the medulla oblongata. So in between midbrain, then there's the pons, and then there's the medulla oblongata. However, something that you should need to remember is that behind the pons you get the cerebellum. It is connected by means of the um, middle cerebral peduncles, and also there are few nerve fibers that are coming through the inferior cerebellar peduncles as well to the cerebellum. So the pons has good communication with the cerebellum, right? First of all, the thing that I would like to say is that the pons can be divided into two regions. Now if I get the pons as this being the ventral aspect, and then there's the dorsal aspect. So the pons can be divided into two portions. The ventral part, of the body or the pons is known as the basilar body, whereas the posterior part is known as the tegmentum. Now, in the basilar, you get multiple nuclei. These are known as the pontine nuclei. Plays an important role in the relaying more informations that are coming from the descending tracts. So eventually what it does is it has its influence on the motor functions. So this include both cortico spinal tracts, cortical pontine tracts, and also some of the uh, fibers that come from the cortex, from the brain through the pons into the nuclei that are found, nuclei of the cranial nerves that are found within the medulla oblongata itself, such as the vagus, the glossopharyngeal, as well as the accessory nerve. So these includes cortico-nuclear fibers as well. So primarily, what the bacilla does is it houses the pontine nuclei, plays an important function in relaying motor information and the descending tracts, and establishes communications between the cortex and the latter part of the brain, which is the which is the brain stem that composes of the nuclei of cranial nerves of 9th, 10th, 11th, and 12th, the hypoglossal as well. So, in addition to that, the tegmentum is composed of, at the more ventral aspect, you get the trapezoid body. Now, I'm not trying to give you this is the sort of the way that most of you have been taught about the pons, but I'll be going into clinical aspects as soon as possible, but just to give you a brief idea about what the structures that are inside. So trapezoid is actually composed of a decussation. This consists of fibers that are crossing from one side of the body to the other. For an example, if there's some sort of a lesion that happens in the trapezoid, what would happen is that there are manifestations in the contralateral aspect. Particularly, these consist of fibers that are crossing from the fibers that are coming from the ascending tracts, or the tracts that brings in sensory information. So there will be some sort of sensory loss. So that need to be kept in mind as well, right? So the trapezoid body is actually a crossing of sensory information, and somewhat there are few motor fibers as well, which includes fibers that are going into the cerebellum as well as the cortex, as well as the other parts of the cortex, as well as the spinal cord, where motor functions has to be carried out, right? So that's the trapezoid body. Now, going further, you see that there are few other nuclei, or there are few other tracts as well. Now, what are these? Now, trapezoid body, in the lateral to the trapezoid body, you get few tracts. Now, I'm using the color blue. I'll be naming them as 1, 2, 3, and 4. From medial aspect to the lateral aspect, these are the tracts. Most medial, there is the medial lemniscus, and then there's the medial lemniscus composed of sensory informations that are coming from the body, which includes proprioception and almost all the sensory modalities that are being carried out by the dorsal column of the spinal cord. So this includes vibration, touch, crude touch, and also even pressure as well. So info from dorsal column, right? Then there's the trigeminal nuclei, or not the nuclei, the trigeminal lemniscus. What does it do? If you can remember, the trigeminal lemniscus carries information from the face. This includes sensory informations of touch, pressure, pain, temperature, and whatnot, everything from the face. So sensory info from face. I'm just trying to bring this in a very concise manner so that you will understand this. There's the medial lemniscus, there's a trigeminal lemniscus, and then more laterally you get the spinal lemniscus. Now, what does the spinal lemniscus do? If you can remember, the spinal lemniscus carries information of pain and temperature, the lateral spinal thalamic tract. Pain, temperature, but below the neck, because more the pain and temperature of the face is however carried out by the trigeminal lemniscus. So if there's some sort of a damage to the spinal lemniscus only, I'm not saying that it is possible, if such a if such an occasion takes place, hypothetically you would get numbness of pain and temperature and the contralateral aspect of the body below the neck. Good. Then most lateral you get the lateral lemniscus, which is involved in carrying auditory fibers that are coming from this includes the vestibular cochlear nucleus, and these information are carried out by the lateral lemniscus. So hearing, involved in hearing, right? Furthermore, you get the to the most dorsal aspect, you get the fourth ventricle. Then there's uh, a white fiber content that is present more or less at the most dorsal aspect. This is known as this even forms the roof of the fourth ventricle. This is given the name superior medullary velum. Right, right. We'll be looking at some of the fibers that are found in the medial aspect of the pons. Now, these are found as pairs. Right. I'll be giving them the and nomenclature with Roman numbers. So 1, tract number 2, tract number 3. So tract number 1, which is present more ventrally, is known as the rubrospinal tract. What does it do? Now these tracts carries information from the usually they are descending tracts, carries information from one of the regions of the brain that is present more or less proximally to the distal aspect, usually the spinal cord, for the motor functions to take place. Now rubrospinal, the name itself implies the fact that it is coming from the red nucleus. What does the red nucleus do? It maintains the action of flexors. Now, our body, mostly what would happen is that the flexors are in better contraction than the extensors. Now, this is made sure by the fibers that are flowing in constantly from the red nucleus. So, if this undergoes some sort of a damage, what would happen is that the plexus will lose its integrity. So, the rubrospinal tract is this is now if you can remember the action of the red nucleus, you can remember the decorticate and the decerebrate rigidity as well, because it is the uh, structure of the brain that plays the distinct part in the difference of the manifestations between decerebrate and the decorticate rigidity. Right, so rubrospinal tract carries information from the red nucleus to the flexor muscles. Good. Then that's one. Then there's the tectospinal tract. What does the tectospinal tract do? Tecto means, now it comes from the tectum. Tectum means that it is from the midbrain, from the superior colliculus and the inferior colliculus. So auditory colliculus. If you can remember, now for certain, if when you see certain due to certain images as well as some movements of objects with sounds, we tend to it's a more or less sort of a reflex. We tend to move our neck towards or away from the particular stimulus. Now this is maintained by the information that is gathered both by the eyes as well as the ears. Now once information are relayed on from the sensory fibers into the superior colliculus, which interprets the vision, as well as the inferior colliculus, which interprets the hearing, and sends information directly to the neck muscles via the pons through these tectospinal tracts. So this carries out uh, movements of the neck. So movements of the neck, descending tracts that are coming from the tectum, from the midbrain. Right. Furthermore, now the third, which is present very rostrally, is the medial longitudinal fasciculus. Medial longitudinal fasciculus. Now, I'm pretty sure that you have heard about this in much of your clinical lessons. Now, medial longitudinal fasciculus, what it does is that it there are fibers that runs between sixth cranial nerve which carries out movements of the lateral rectus and integrates with the function of the third as well as the fourth cranial nerve. Now, for conjugate vision to take place, now conjugation of eye movements. For an example, if you are looking at a particular side, now if I'm looking to the let's assume I'm looking to the left, then if I'm looking to the left eye uh, should be in abduction, whereas the right eye should be in adduction. Now, for the left eye to be abducted, uh, its lateral rectus should be working, and for the right eye to be adducted, its medial rectus should be working. Medial rectus is maintained by the third cranial nerve, whereas the lateral rectus is carried out by the sixth cranial nerve. Now, for this function to happen, both of these has to coalesce and work in a more simultaneous manner. So, therefore, both lateral rectus and the medial rectus has to be their working should be uh, connected by means of some sort of a circuitry. Now that circuitry is carried out by the medial longitudinal fasciculus. So medial longitudinal fasciculus is the rostral medial form of the tract that you see within the pons. If this is damaged, now this can happen due to multiple sclerosis, and there are multiple reasons that this might lead to some sort of a lesion. And if this happens, you will lose the conjugate movements of the eyes, and also there will be the possibility of horizontal gaze palsy, because now they are not working hand in hand with one another. Now this is an important structure, right? Now looking back, what else did we miss? Right, then there is then more laterally you get the spinocerebellar tract. Now I use this SCT, the spinocerebellar tract. Again, you have to know this. Now once what does this do? It carries information from the from the cerebellum to the spinal cord for the motor functions to take place. So this is more or less a descending fiber. And also now what happens is that the cerebellum carries out is rapidly involved in movements, coordination of them, as well as maintain the integrity of motions. So once it modifies a certain motor plan that is from the prefrontal cortex, sometimes it sends information directly to the spinal cord for the motor fibers where certain actions are to be carried out. So this is carried out by these structures. So if this undergoes some sort of damage, what would happen is that the relaying of information from the cerebellum to the muscles will somewhat be hindered, and therefore there is a possibility that you might get what you get. It's ataxia, or the disorganized movement is something which we prominently seen in such patients. Good. So this is more or less the thing that you need to understand. Now furthermore you will be seeing few other fibers as well, very easy but still need to know. Now I'll use, right, what else do you have you got now? Then you have the two nuclei. Now what does the pons contain? Pons contain few cranial nuclei. These cranial nuclei include the third, fourth are present in the midbrain, and also a part of the fifth as well. But the majority, which includes fifth cranial nerve, the trigeminal nerve, both the motor as well as the sensory, are present in the pons. In addition to that, you get the sixth cranial nerve, the abducent nerve, and also the facial nerve. Now, because of the intertwining of the facial nerve, I'll go through this. It forms the facial collicule as well. So seventh cranial nerve and also the eighth cranial nerve. Right. These are the cranial nerves that you see. First of all, the fifth cranial nerve. The fifth cranial nerve, I'll use purple. The fifth cranial nerve has motor as well as sensory. This is a trigeminal. This is the trigeminal nuclei. The motor functions are to the masticatory muscles that are the temporalis, masseter, and the lateral and the medial pterygoids. So the function of this is dependent on the nuclei that is residing within the pons. And then there is a part of the sensory nuclei. Part of the sensory nuclei. If you can remember, this is more or less involved in perception of proprioception and vibration informations that are being relayed from the face. So the sensory nucleus of the trigeminal is of three folds. It consists of the mesencephalic nucleus, which is present in the midbrain, the principal nucleus that is present in the pons, and the spinal nucleus that is present towards the medulla oblongata as well as the spinal cord as well. So this includes the sensory nuclei is of the trigeminal nerve that is present in the pons is more involved or have a higher penchant towards identifying and identifying and perceiving, not perceiving, but relaying informations that are coming, information from the proprioception and of vibration cortex to the sensory cortex. Good. So that is fifth cranial nerve. Then you get the sixth cranial nerve. What is the sixth cranial nerve? Sixth cranial nerve is the abducent nerve. Now, if this nuclei is damaged, what would happen is that the lateral rectus will not move. Hence, you would see a horizontal gaze palsy. So, abducent nerve palsy is something that you would see. Usually, now I'll be looking at this in a more detailed manner once we go to the lesions, right? So, the sixth cranial. The seventh cranial nerve is the facial nerve. I'll take. Then there's the facial nerve. Seventh cranial nerve. Facial nerve. If you can remember, if you see, the facial nerve winds around the abducent nuclei, forming an impression in the uh, dorsal aspect, of the pons, which is seen from the external surface, that is known as the facial colliculus. Now, facial colliculus is because of the fact that there's a nerve that is running behind it. No, I mean in front of it. Carrying information from the seventh cranial nerve. So, if this is damaged by any means, there is a possibility you would get a facial nerve palsy, uh, usually of lower motor neuron origin. So, lower motor neuron facial nerve palsy is something that is evident if there is a damage to the seventh cranial nerve nuclei. So the facial nuclei. There are multiple muscles which are regulated or which are under the control of this nerve and facial muscles. And in addition to that, there are few fibers that are coming from other nuclei as well, which is important in uh, sensing taste sensation of the anterior two-thirds of the tongue. Now there is a separate nuclei that is present close to this, which is known as the nucleus of tractus solitarius. Nucleus of tractus solitarius. I'll use the abbreviations TS. So which relays information of taste on the anterior two-thirds. It also consists of few sensory fibers as well, which sensory fibers that are coming with the trigeminal nuclei. So that is also found hitchhiking with the facial nerve. So the seventh cranial nerve has fibers that are coming from the nucleus of the tractus solitarius and also fifth trigeminal nerve, the trigeminal nerve sensory nucleus, right? Right. In addition to that, there is also parasympathetic fibers from the superior salivatory nucleus. What does this do? This now the facial nerve has fibers of all these. The superior salivatory nucleus is of parasympathetic origin. It sends information or sends nerve fibers or sends nerve signals to the lacrimal gland, to the mucous glands that are found in the nasal fossa, as well as the salivary glands. The salivary glands includes the, the submandibular, the sublingual, as well as uh, the glands that are found in the parotid glands, right? So this carries information, and what it does is that it secretes saliva. Good. So seventh cranial nerve has multiple functions. Right? Fifth, sixth, seventh, and then there's the eighth. Eighth is composed of two nuclei, which is one would be the vestibular nuclei, vestibular complex. That is the word that we use, vestibular complex, and then which is important in maintaining posture, the balance and everything. So it has this function. And in addition to that, you get the cochlear nucleus as well. Cochlear nucleus is involved in hearing. What it does is that there are information that comes to the cochlear nucleus via the nerve fibers that carries auditory information, and this is sent into the superior olives, and from the superior olives it is sent via the trapezoid body. As I said, most of the sensory fibers are sent to the contractile aspect via the trapezoid body, and then it ascends, as if you can remember, it's the fourth uh, tract, which carries information of hearing. So lateral lemniscus. So from the hearing nerve fibers comes to the superior olive, to the cochlear nucleus. Cochlear nucleus sends information to the superior olives. Superior olives sends information via the trapezoid body through the lateral lemniscus into the inferior colliculus, and from the inferior colliculus it is sent via the thalamus to the auditory cortex where perception takes place. So this is the sort of the track that happens. So it's a ascending one, carries sensory information still. This is how it does its work. Good. Now we have gone through everything that is given for the pons. Now something that you should know is that the blood supply comes from the basilar artery. There are few fibers that you might want to know, but not very important as such. If you are really keen, I can. If this is the medial aspect is provided by the paramedian branch, then there is the short circumferential branch of the bacillary artery, then there's the long circumferential branch along with anterior inferior cerebral artery. So there are multiple branches now because of the provision by such multiple numbers of branches. There is a possibility that once a simple branch is occluded by means of a thrombus or some sort, there is a possibility of a pontine infarction to happen, and each giving rise to different sorts of manifestations in patients. That's the beauty of neurology. You see different patients, and still what you have to take in is the fact that this is actually a pontine lesion that has happened over time, and you need to now sometimes the management does not change. That's something very common in neurology, but still the beauty of the symptoms that you see in patients are quite different from one another, and this is what you need to relate, right? Now, what we are looking at is the lesions. Very easy. Should remember. Now, I'll give you few things overall that you need to remember. Now, we are going to look at the lesions or the pontine lesions that might happen in an infarction and look at its manifestation. Of course, this is going to be a bit difficult when compared to that of the normal structure, but still this is the sort of thing that you should understand in your final years to distinguish the actual location where strokes happen. Now I have drawn a simple version of the pons, and now the first question comes. Now there are multiple different manifestations and different people coming to you with multiple symptoms, and you need to identify and localize the stroke. Now, how do you know it's a problem in the pons? So why pons? If the patient, now you should remember this. If the patient says of a hemiparesis, hemiparesis in one side, let's assume it's going to be a left side, hemiparesis in the left side, but with a facial weakness in the other side. In this case, it's the right. So the contralateral side. So a patient who says both upper limb and lower limb both upper limb and lower limb involvement, so hemiparesis in one side with facial weakness in the opposite side. Now you know this is a problem. It is not, if once the upper limb and the lower limb are both involved, you know that it's a lesion that is present in the upper part of the brain, upper part of the central nervous system, so not lower down, so something above. Either it's the uh, cervical spinal cord or else above than that. Now the problem arises whether you have to distinguish whether it's actually from the internal capsule, the frontal cortex, or whether it's a midbrain stroke. Now you know that the seventh nerve or the facial nerve is actually coming from the pons. The lower motor neuron does not cross; it goes directly from the pons to the particular to this particular site. And since this is present in more or less a contralateral way, you have to know that this is a problem that might be affecting the pons. For your confirmation, just note whether there are attributes to the abducent nerve and the facial nerve. Now, facial nerve I already discussed, so the abducent nerve. Whether there is any abducent nerve palsy. If there is so, then of course you can come to a more or less a conclusion that this is a stroke that has happened in the pons. Right. Looking back, now the bacilla consists of motor fibers. Then there was the crossing over at the trapezoid body and the tegmentum. In addition to that, if you can remember, there was the sixth cranial nerve, the seventh cranial nerve, and there were multiple sensory tracts which included the medial lemniscus, the trigeminal lemniscus, the spinal lemniscus, and the lateral lemniscus. In addition to that, there was also the spinocerebral tract as well as the mid-cerebellar pedunculus in the more lateral aspect. Right. So coming back, now there are a few syndromes that you should know. The first one, initially, as I said, there are multiple branches which provides perfusion to the pons, which includes the medial basilar artery as well as the long and the short circumferential branches, as I said above. Just we are initially looking at a ventral sort of an infarction, a ventral infarction present in the anterior aspect of the pons. Are we clear? So ventral infarction. Now what are the ventral infarction? The first one is the ventral infarction. Then what are the structures that are damaged? These are the pontine nuclei in the basilar part. The pontine nuclei and also the fibers which includes the corticospinal as well as the corticonucleus. But of course, only one side is damaged. So therefore, corticonucleus doesn't have that much of a problem because there are bilateral innervations. Dysphagia cannot happen through a unilateral sort of a lesion. It has to be bilateral. But if you can remember, the corticospinal will have its impact because these fibers crosses over in the lower part of the medulla oblongata, in the upper part of the medulla oblongata to the opposite aspect. So if The left side undergoes some sort of a lesion. If the corticospinal tracts are affected, then there will be manifestations in the right side, because it will cross over the nerve fibers usually cross over distal to that of the pons in the medulla. Therefore there will be problems in the right side. So the corticospinal tracts are damaged, therefore there will be hemiparesis, not on the ipsilateral side but of the contralateral side. Are we clear? So hemiparesis, it could be also hemiplegia as well. It depends on the extension of the lesion. What else? Now it can affect the seventh cranial nerve as well, but the seventh cranial nerve is to the ipsilateral side, to the side of the lesion. So you would see facial nerve palsy in the ipsilateral side, IA. Right. What else? There will be sixth cranial nerve palsy as well. So abducens nerve palsy. What would you see? You would see that now if you now again the sixth cranial nerve is the sixth and the seventh cranial nerve is passing on to the ipsilateral aspect. So if there's an infarction in the left side, what this is the right eye and this is the left eye, you would see problems in the left lateral rectus. It will not be working. Therefore, with the action of the antagonistic muscle, the eye would be in an adducted position. So you would see the eye in a more adducted position. Now this would be very prominent if you ask the patient to look to the side of the lesion or the left side. If you ask the patient to look to the left, then the right eye would function, but the left eye would not. It will not move. It will not move much, whereas the left right eye will move to the will move in a more adducted position. Are we clear? Right. So the sixth cranial nerve palsy again in the ipsilateral aspect. So this ventral infarction does not affect the other components of the pons. This is given the name Miller-Gubler syndrome. So should know the name Miller-Gubler syndrome. What else? Now something very similar to it's the same thing actually, but sometimes it extends to the tegmentum as well, a little bit to the tegmentum. This will involve a region which is given the name PPRF. Okay, if you have done your ophthalmology appointment, you would know this. It's the paramedian pontine reticular formation. What is the function of the paramedian pontine reticular formation? It's something like this. The PPRF will have connections with the sixth cranial nerve. The sixth cranial nerve, which controls the lateral rectus of the ipsilateral side, will have connections with the third cranial nuclei and the fourth cranial nuclei via a structure which is known as the medial longitudinal fasciculus. So what does the PPRF do? PPRF, now if you ask the patient to follow a certain object, follow a path, the path of object, or go in pursuit, following is done by, now for let's assume that you take an object across this vision of the particular patient in a leftward motion. Now what would happen is that the left eye would abduct and the right eye would adduct. That is the normal phenomena that is apparent in most people. So that is pursuit or tracking an object. Now this is possible because of the action of medial longitudinal fasciculus. It's because the sixth cranial nerve constantly sends information for the third cranial nerve for the smooth actions to take place. But by some means the medial longitudinal fasciculus is damaged, what would happen is that there is a possibility that this would not be there. The tracking of the object would be haphazard and it will not function well. The left side eye would abduct because it's the action of the uh, sixth cranial nerve, but however the third cranial nerve would not comply and it will not show that much of motion. It will not do a good adduction, and therefore you would know that there's the problem is within the medial longitudinal fasciculus because the sixth cranial nerve is actually working. But if there's a damage to the PPRF, now what does the PPRF do? PPRF is involving saccadic motions of the eye. Saccadic means now abrupt motions directly to a particular aspect. Now this is quite important in uh, tracking objects, pursuing, and now as we were in our evolutionary state, we were hunters and gatherers. So hunters require these sort of motions in the eye for the for their daily living, right? So saccadic motions is carried out by the PPRF. PPRF does this by involving the sixth cranial nerve. It sends information to the sixth cranial nerve, causes abduction of the left eye. Along with that, it sends information to the medial longitudinal fasciculus to the third cranial nerve for the adduction to take place. But if the PPRF is not working, you can always ask the person and cause a if you ask the person, he can abduct the eye. There's no problem because the consciousness of the voluntary muscle is there, is intact because sixth cranial nerve is working. But the PPRF, once it is damaged, if you turn the head, there is a once you turn the head, you need the sixth cranial nerve as well as the third cranial nerve to function for the tracking purpose. That's how tracking is done. Once you turn the head, or once there's abrupt sort of a motion, still the eyes would be looking at a particular object. The focus would be fixed because of the action of the sixth cranial nerve and the third cranial nerve, because it is being stimulated by the PPRA. But once this happens, the PPRF, since it is not working in this case, once you turn the head, there will be no abduction, no adduction as such to be seen, because there will be no saccadic motions, no abrupt motions. Hence, you would see a dull eye phenomena, dull eye sort of a phenomena. Are we clear? Not bilaterally, but on the once you turn the head to the ipsilateral aspect. So a unilateral dull eye phenomena. Are we clear? This is evident only when you turn the neck. But of course, if you ask the patient to look at to a particular site, there will be no problem. It will have its normal way because the medial longitudinal fasciculus as well as the sixth cranial nerve and the third cranial nerve is intact. And also the eyes, once the patient is in normal state, in looking forward, the eyes would be in the middle in the middle without any sort of a disconjugation. But if there's sixth cranial nerve palsy, of course, there is a possibility it will pass on to the medial aspect. Now, this is not evident. Of course, it's very hard to differentiate a sixth cranial nerve palsy from a PPRF lesion. But still, again, another thing is, now this could be done. Now, there is something called vestibulo-ocular reflex as well. If you can, I'm not using this video to go through that, but that is also involved in such motions. But the thing I have to say is that it's very hard to distinguishingly identify the sixth cranial nerve from a PPRF, but by few motions you can do so. So here you would see the same sort of lesions. You would see contralateral hemiparesis with the facial nerve palsy of the ipsilateral side, but you would not see the sixth cranial nerve palsy, but a lesion in the PPRF, leading to a unilateral or the ipsilateral or the same side ipsilateral horizontal gaze palsy. Horizontal gaze is somewhat problematic because of the inability to carry out these saccadic sort of motions of the eye. Now this is given the name Foville syndrome. Are we clear? Now the only difference between the Foville's and the Miller-Gubler syndrome is that Foville's will have a horizontal gaze palsy of the ipsilateral side, but in Miller-Gubler you would get a sixth cranial nerve palsy. Are we clear? These are the ventral lesions of the pons. Are we clear? Right. Now we will be looking at the lateral lesions. I'll be using the same. A lateral lesion would be more or less towards this aspect. Look at the structures which are being involved. The ventral part of the pons is involved, so there will be contralateral hemiparesis. Are we good? Then the sixth cranial nerve is usually spared because it is present in a more medial aspect. It is spared. However, the structures, the sensory tracts, which I said, the medial lemniscus, the spinal lemniscus, and the trigeminal as well as the lateral lemniscus are involved. So you would see the inability to carry out proprioception, inability to sense proprioception, or there will be sensory deficits from the throughout the body, because the trigeminal nucleus is also involved. So the trigeminal nuclei, which actually carries information from the opposite side of the face. So because it has already now the information that is coming through the trigeminal nuclei has come and crossed across the trapezoid body, reached the trigeminal nucleus, and from the trigeminal nucleus it has come up to the trigeminal lemniscus, because now therefore you would the patient would say of a sensory deficit in the contralateral side, not the ipsilateral side, but the contralateral side. Contralateral side of sensory deficit in the face, the body, which includes proprioception, vibration, touch, pain and temperature, because the spinal lemniscus is also involved, and also defects in hearing, because the lateral lemniscus is also involved. In addition to that, the spinocerebellar tract as well as the middle cerebral peduncles are involved. Therefore, the patient will show hemiataxia, discoordinated movements, as well as the inability to maintain posture, because the cerebellum is not in function. Are we clear? This is lateral pontine nucleus, lateral pontine lesions. Lateral pontine lesions, ventral pontine lesions, I have gone through both of them, and now will be looking at a more or less now we are looking at a bilateral sort of a lesion. This bilateral lesion, we term it as locked-in syndrome. What does locked-in syndrome do? Now it's a bilateral sort of a lesion. Since it is bilateral, this is given the name locked-in syndrome. You would see that there is bilateral hemiplegia or hemiparesis. Now this happens when there's infarction or thrombosis at the basilar artery. So more, a larger part of the brain pons is now gone, infarcted. So bilateral hemiparesis. Along with that, there will be bilateral facial nerve palsy. You will not be able to move any muscle. Not any muscle, but I'll go through that. So quadriplegic, quadriplegic facial nerve palsy, and also since the PPRF as well as the sixth cranial nerve is also involved in such lesions, you would see bilateral abducent nerve palsy. In fact, this can be termed as horizontal bilateral horizontal gaze palsy because now uh, all these are not working. Horizontal gaze palsy. Both PPRF, medial longitudinal fasciculus, as well as the sixth cranial nerve are not working now. Therefore, horizontal bilateral horizontal gaze palsy. But with all of these, still vertical motions of the eye would be intact. Vertical motions are intact. Vertical motions of the eye. This is because the third cranial nerve is intact. Because it's a lesion in the pons, not the midbrain. Therefore, vertical motions are possible. Still, the patient will be able to sometimes even blink, move the eye up in a upper and in a vertical fashion. So these are possibilities. Blinking again, you would see that it's very problematic, but still it is sometimes seen in these patients. What else? Now, in these circumstances, the reticular formation of the brain is spared because the reticular formation you would see it in the medulla oblongata as well. So this patient is actually locked in, it's in a trance, it's in a locked in trance. The patient has not lost consciousness. He's not conscious. He's not he has consciousness. Consciousness is there. Consciousness is present. He can hear you. He can uh, uh, process things as well. If you talk to him, he perceives these things. He can even interpret images, but still will not be able to move other muscles in response. Will not be able to speak. Only the vertical motions of the eye is present. Apart from that, all the other motions are paralyzed. So this is given the term locked-in syndrome. So it's a bilateral lesion of the pons. In addition to that, you would also get perhaps few other lesions as well, which I will not be going through. There are, if these names come across again, you can obviously know that this is a pontine lesion. So there is the Raymond syndrome. It's a ventromedial sort of a pontine lesion, and there's Gasparini syndrome, as far as I can remember, and of course there are a few others as well. Just need not split your hair upon it, but know that there are a few others as well. So these are the major syndromes, pontine lesions that you should know, and I have gone through them. Perhaps now, since I have gone through it in a very methodical manner, it would be easier for you to understand them rather than memorize it. So looking forward, we'll be now there has I'm trying to get some feedback from you for the other lessons as well. Now, this was one thing that I wanted to discuss, and for the next lessons, there have been requests about the cranial nerves and its lesions as well. Perhaps I'll be looking at facial nerve in the next lesson, and we'll see how it goes. Right. Thank you. We'll meet with the next video.